Hello, I'm Yasser Janab, Interventional Cardiology Center and Heart Center, presenting the case Endovascular Approach for Revascularization of an Occluded Central Aortopulmonary Shunt. Despite advancements in surgical approaches for congenital heart defects, systemic-to-pulmonary arterial shunt implantation remains a valuable and the most common procedure for the initial palliation of central complex congenital heart disease with inadequate pulmonary blood flow. Various types of shunts are currently created, such as classical or modified PT shunt, which were created between the subclavian and pulmonary artery. Central aortopulmonary shunt from aorta to the pulmonary artery. In patients with small or diminutive pulmonary arteries, central aortopulmonary shunt is preferred. Our case is a 30-year-old man with complex congenital heart disease, previously undergone palliative surgery to place a central shunt between ascending aorta and main pulmonary artery. After 1 year, he presented with exertional dyspnea, fatigue, and exacerbation of cyanosis, with a reduction in oxygen saturation to 65%. Echocardiography and CT angiography of aorta demonstrated occlusion of central shunt. Due to a very high operative risk, heart team decision preferred percutaneous transluminal angioplasty over redo surgery. Shunt stenosis and occlusion can develop gradually or suddenly, leading to restriction of pulmonary perfusion with subsequent clinical signs and symptoms including respiratory distress, severe hypoxia with low blood oxygen saturation, and cyanosis. Most of these patients were judged a high-risk candidate for any further surgical correction. Many cases of shunt occlusions, either PT shunt or central shunt, were reported that successfully treated with stent placement in shunt in neonates and infants. Transcatheter palliation may offer a valuable treatment in adults. However, catheter intervention may be complicated by complex anatomy in these patients. CT angiography showed occluded central aortopulmonary shunt, anomalous single-trunk coronary artery from ascending aorta, pulmonary atresia, and large ventricular septal defect. At the beginning of our procedure, the ambulance catheter was selected in anomalous single-trunk coronary artery from ascending aorta, which divides into RCA, LAD, and left circumflex. We had right femoral artery access. We also had ambulance left guiding catheter and Camaro O35 support catheter. We applied hydrophilic O35 trauma guide wire and O18 hydrophilic wire to engage the occlusion. As O35 hydrophilic guide wire and O18 hydrophilic guide wires were not successful to pass the occlusion, we applied STO-30 to pass the lesion, which was not successful. At the end, we applied Conquest Pro 12, which is a CTO guide wire, which was successfully past the occlusion. Predilation over aorta 14 wire was done using 1.5 and 2.5 mm balloons. Afterwards, support catheter could cross the lesion to change the O14 wire to O35 ambulance superstiff wire. Balloon passage was done over O35 stiff wire. Balloon predilation was done with 6 mm balloon. You can see opening of central shunt after ballooning. During attempts to deploy 9 mm balloon expandable stent, the stent was stripped when trying to deploy the stent. The stent was snared. However, it was inadvertently released in descending aorta and was found in the right internal iliac artery, which was decided to be left in place. Second attempt to deploy a stent was done with a 9 mm balloon expandable stent from left femoral artery access without guiding support while visualizing the ascending aorta through line sheet from contralateral access with good result. The patient was admitted to intensive care unit. Oxygen saturation increased from 65% to 80%. Sinus rhythm was converted to atrial flutter. Electrical cardioversion to sinus rhythm was done successfully after transesophageal echocardiography showed no LA thrombus. The patient was discharged on aspirin and rivaroxaban. In summary, transcatheter approaches for stenosed or even occluded shunts may offer further palliation in selected adult and infant patients with complex congenital heart disease who are not suitable for surgical repair. Stenting the PT shunt and central shunts has become an attractive alternative to surgical treatment, resulting in significant clinical improvement. Thanks for your watching.